introduce our next speaker, we have Dr. Ralph Zhang, a colleague of mine, and who is a consultant of A&E of Prince of Wales Hospital. He will talk about simulation training. Ralph is the honorary clinical associate professor of the AEMAU, and has extensive experience of medical education at all levels. Ralph is also a faculty member of Comprehensive Simulation Educator course and a visiting scholar of Center of Medical Simulations. So we were colleagues and we worked in Prince of Wales Hospital together, and Ralph was one of my mentors when I was a trainee, and I must say he is fantastic simulation expert in organizing, conducting, and also in debriefing simulation educations activities. So without further delay, Ralph, please.
Thank you very much, Alex, for your very kind introduction. And first of all, I also would like to thank Calvin and Colleen for the A&E Medicine Academic Unit for inviting me to talk for simulation education, the pinnacle of education. Actually, it's some stress to me after the great talk of Dr. So that follows Dr. So's very innovative way of e-learning. For my talk, we'll go back to some more basic stuff. Disclosure, I have nothing to disclose and no conflict of interest. Here we can see the learner using the task trainer practicing transvaginal ultrasound scan. They use the haptic technology with some tactile elements. And this, several of us were engaged in simulation activity. They were videotaped for video debriefing for faculty development. And these two virtual reality were employed to practice interview in terms of media and also in disaster field management. In this shows the multidisciplinary involvement in situ simulation. These were videotaped and also with subtitles included, because this acts as system integration before the implementation of eCPR and activity as a multidisciplinary project. And here shows the debriefing activity after also multidisciplinary simulation in trauma team training. For scope for my sharing today would include some overview of simulation as medical education tools, including some history, how it relates to education theories, and some key components. After that, we'll talk something about debriefing, and then simulation cycle and also evaluations. In mainland China, more than 1,000 years ago, in the Song Dynasty, there were bronze figures for people to practice the acupuncture. The acupuncture marks were pierced, and inside the acupuncture figure, there were wooden internal organs, and then the figure were filled with water, and the acupuncture points were sealed with wax. The learners could practice whether they find the correct acupuncture marks. This serves as learning, teaching, and also assessment of learning. In the Western part, more than 200, 300 years ago in France or in Italy, there were mannequins to simulate pelvis and also flexible uterus, flexible fetus for the birthing simulator. So the simulator is displayed here. There was a glass uterus in the pelvis. The midwife and also the doctors were tested to deliver the fetus with this simulator. It was probably the first example of learning to give the simulation training and assessment. Back in emergency medicine, in the 1960s, the Risuxi ND and Andy appeared, the man and the woman mannequin. These mannequins were used for practicing cardiopulmonary resuscitation skills and also mouth-to-mouth ventilation skills. For the literature in the 1970s concerning emergency medicine, the first one appeared concerns about emergency department administration, the in-basket exercise, that mimic a busy emergency department with the doctor receiving lots of phone calls, documents, memos, mails, and how the doctor could handle with so many things together. The doctor needs to set priority and have good administration. And then in the 1980s, the literature came for medical simulation in disaster casualty management training. The doctor would need to set up a disaster field in which all the medical facility were destroyed in disaster and see how it managed. So coming back, what is simulation? There are so many definitions of simulation. From the Healthcare Simulation Dictionary, it is a technique that creates a situation or environment to allow persons to experience a real event or that is close to a real event for the purpose of practice, learning, evaluation, and testing. So this definition already contains most elements for the application of simulation. The applications for the purpose of 1, training and education, 2, assessment, 3, research, and 4, for the system integration. So why do we use simulation? In the traditional way of see one, do one, teach one, actually would be very effective for the learners if there was a good teacher. But in the era of patient safety and quality control, we can't practice on all the real patients. So we simulate the real thing. This kind of active learning would be most engaging to the learners, and the learners would learn the most. The reason for doing simulation and to simulate the real thing or simulate the almost learners that resemble the real thing could be explained by the COPS experiential learning cycle. So learners experience the scenario, they then sit down and reflect, think deeply how to make sense of it. Like for example, when a situation of a patient with blood pressure 80/60 with pulse 120, they experience that, they then reflect. What does that mean? That could be a case of shock. And then we conceptualize. That means take the concept out of our mind. So what kind of shock is that? In combining the context, possibly be hypovolemic shock, then we experience that, experiment that, we give some fluid and see whether it works. So I find the diagram from the CSAC course. The CSAC course led by Dr. So is very comprehensive to show the different components of simulation. So this is the scenario. There are lots of logistics here, including scenario writing, scenario running, and the debriefing here. Very important to use structured debriefing. Another angle to look at the dimensions of simulation is described by the Choi et al. Paper that include the scope of simulation, modality of simulation, and environment of simulation. Scope refers to whether there's specific task or skill, whether it's partial or full procedure, whether it's scenario-based, or whether it's clinical pathway. Modality refers to whether it's task trainer, mannequin, standardized patient, computer-based like virtual reality, or mixed modality. Environment refers to whether the simulation is in situ, inside a simulation center, or in virtual environments. To ensure simulation activities brings good learning outcome, the safe container is needed. In the original paper from Jenny Rudolph and Robert Simon, the 4 important components to bring psychological safety include the respect, include the fiction contract, include attending the logistic details, and then clarify expectations. So this is illustrated in this paper together with some other elements like the basic assumptions of the learners, consent and confidentiality, and orientation to the sim environment. In this paper, it added something more to the psychological safety. It includes psychological safety of the faculty, including managing the logistics for instructors, and also respects for the instructors, and some other issues like taking in consideration into social and cultural norms, and also taking account into interpersonal or individual factors. Also in the same paper from Jenny Rudolph and Robert Simon, the relationships of fidelity, realism, and engagement is here. The main purpose of stressing the safe container is to make learners engaged. Fiction contract is here. Physical fidelity is the simulator understood as how it resembles, how it looked like, how it feels like the real situation. But the conceptual fidelity and the emotional fidelity are more important to bring about realism in order for the learners to engage. The emotional fidelity part could be quite complicated, but put it in a simple way from the Russell's paper, from the circumflex model of affects. If learners are activated, they could learn because they could retain the memory. They were interested in it, or they at least pay their attention to them. Either they are excited or they may be nervous. They get a good memory. If learners are deactivated, they could either be bored or they could be relaxed. So in this circumflex model, either they're pleasant or unpleasant, could also in the emotion. So for the traditional or the most traditional pedagogic exercise, the emotions of the learners is situated here, whereas in the simulation exercise, the emotional state would be activated like here. However, the effect of emotion is more complex. So with different emotion could change the attention, memory, and judgment. Say, for example, the learners would pay attention to the information that is congruent with the current emotional state. And in the memory part, the learners would remember the elements that were currently related to the emotional trigger in time, space, and concept, and the peripheral information. And also the judgment. Like say, if a learner are sad, they are more likely to focus on the details rather than the big picture. So much so, we go to the debriefing. The debriefing part is important, as in the COP cycle, the debriefing helps the learners to reflect and make sense of what's happening and the experience. So the debriefing is conversation so that the learners could analyze their action and reflect their thought process, psychomotor skills, and emotional state to improve or sustain the performance. Effective debriefing could increase the effectiveness of the learning activity so as to get learners to get the knowledge, skills, and possibly change the behavior. So how can we make our debriefing more effective? There are so many debriefing methods, but there are several elements which are common, no matter which debriefing methods are used. One, to ensure the psychosocial safety. Two, to have a debriefing stance or to have a basic assumption of the learners. They are intelligent and keen to learn and want to improve the performance. And three, and establish the debriefing rules and also address the learning objectives. So for our role as facilitator is to engage and motivate the learners. We assist learners to reflect on their actions and analyze the performance. We help the learners to identify the performance gap. We allow the participants to learn to talk more, but what they talk about should be linked to the learning objectives. We also need the engaged learners. And facilitators talk should also close the performance gap of the learners. Many times we facilitate, but not teach, instead of giving direct feedback, which is more one way. In the facilitation, it is two-way. And many times instructors talk too much. In some, also in our universal masking era, we can't see the facial expression. However, we should be aware of the body language and also the nonverbal communications. In the debriefing part, we should be clear about the learning objectives and maintain a safe environment. The structure of the debriefing, we talk about the 3 phases or the 4 phases of debriefing, including reaction, understanding, summary, and also sometimes we use the advocacy inquiry type or any other method that would be useful to bring about the learning objectives. In implementing a simulation activity, the following steps are used. In the preparation of the simulation, it takes place before the simulation starts, including identifying the learner's need, the learning objective, designing the simulation, and finding the simulators, etc. Briefing for the faculty and also the learners. The real simulation takes place. The debriefing to help learners to reflect, and then reflect and for the learners to make sense of the simulation. After that, evaluation for the success and limitation of the simulation events. We believe effective simulation could bring good learning outcome. However, some would look into whether this could translate into the different levels of learning, including the level 1 satisfaction, level 2 learning, level 3 behavioral change, and level 4 impacts. So in this systematic review of assessing teamwork in trauma resuscitation, we look into how many levels of Kirkpatrick learning outcome were studied. As expected, most of the studies involved the level 1 and level 2 outcome, and only one paper have the level 4 outcome. All were positive. Another perspective to look at simulation activity is the sim zone concept. It was brought forward by Brosnan and Winston. It is a system for matching for simulation development and delivery approach to specific learning needs. So for zone 0, it includes the learner learn alone. The computer give all the feedback. It is for auto feedback or skill practice. So it would be like the virtual patient simulation discussed by Alex yesterday. And then Zone 1 include the procedure skills workshop, clinical orientation. So that would be like practicing on the task trainer, like the transvaginal ultrasound machine. And Zone 2 include the mock cooks and acute situation training that will include some partial team involved. And Team 3 would be the immersive simulation exercises that applies to crisis team training and development. And this most of the time would involve in teamwork training. And Zone 4 was the real life. So the purpose of the Sim Zone was that to support and differentiate different types of learning so as to guide the organization of simulation faculty training and also clarify learning needs of different participants. There are some limitations of simulation that would include the realism issue. No matter how sophisticated the simulators are, people would argue there are something not resemble the real situation. There are also resource implications. They're expensive, psychometric consideration, and some would think whether it could transfer to actual clinical setting. During a COVID pandemic, there are so many challenges of immersive simulation. And many times they were stopped because of shortage of clinical staff, learner safety concern, PPE shortage, and also restriction on international travel. So how do people respond in the COVID regarding simulation education? So most of the face-to-face teachings were canceled. They were replaced by online education strategies like webinars, virtual classroom, recorded lectures, and online courses. However, there was still some efforts in the more distance learning for simulation training in the literature in the COVID pandemic. So this one studied the use of personal protective equipment, use of high-flow nasal cannula, endotracheal intubation, and prone situation. So in this one, the students used the mannequin to train the technical skills. They record themselves and upload the training videos. The experts provide some remote feedback and the students review. So this serves as some kind of deliberate practice and some community of practice. Another international survey on how the distance healthcare simulation do in the COVID-19. So the main conclusion is that many procedural simulations and team-based simulation need to be conducted in person, would be more effective as expected. However, simulations with some more knowledge base or with some standardized patient could have shifted towards online education. It also identified or re-echo the importance of community inquiry theory framework in the e-learning. So the teaching presence, social presence, and cognitive presence. In the future, our simulation, what will it be? In this particular paper, it pointed out more technology and more advanced and new technology would appear and would be seamlessly integrated into the curriculum. Artificial intelligence and data science would be incorporated, and the culture of simulation would be attributed to improve teamwork and would decrease rates of medical errors. The integrated simulation training would be integrated into mandatory signposts like credentialing. So that's all for my sharing, and thank you very much for your attention.
So thank you so much, Rob Zhang. Again, really wonderful and insightful talk today, and thank you so much. Are there any questions from the floor? Let me see. So no questions so far. So maybe I can ask the questions. So you have talked about the so-called countermeasures of conducting simulation training in COVID-19. So as you know, in Hong Kong, we are still in the midst of this COVID-19 pandemic. Are there any local experience that you can share with us how to provide simulation training to our trainee?
Well, thank you for the question. I must say for the immersive type of simulation that tends to train team-based or non-technical skills like communication, leadership, it would be quite difficult to conduct it online. Whereas the using online teaching of knowledge and also maybe some technical skills like what in the literature and what Dr. So had mentioned about some technical skills with the theoretical background knowledge that could be conducted via the online method. Nevertheless, we are aware that some international simulation centers do conduct their simulation teaching online, but then they have shifted some way from their traditional simulation teaching. They will have need to the participants to have an agenda for improving, like say, trying to solve a problem in their local institution through simulation. And then through the simulation training, they help individual participants to discuss and solve that problem in the institution. Also would be coupled with some debriefing, because debriefing could also be practiced via online. So there are some aspects which can be done without face-to-face. But for us, when the pandemic, when the surge is a bit down and we can have some face-to-face, we'll resume our usual simulation type of training face-to-face.
Yeah, so Ralph, maybe we can answer another question. So Kate asked, do you think it is possible to introduce more debriefing in a clinical setting, and what could that look like? Well, that's interesting questions.
Thank you, Kate. I think it is our ongoing thinking that we have more, well, actually, I should put it this way, with the debriefing part, it could take many forms. Many times we use direct feedback because it's most use the least time. But with the more exploring the underlying frame of our colleagues in a clinical setting, it will be more. It needs some efforts from both the facilitators and also the learners. Besides, in our clinical setting, we need to have the safe container for the effective debriefing to take place. So we should be consciously to create the safe container elements as mentioned. But I think this is the best way for us to improve ourselves as the COPS learning, experiential learning cycle.
Yes. So Thank you. I see there are more questions coming, but for the interest of time, we really have to move on to the next speaker. So for those who have questions and answers, please send Ralph an email to ask him directly. And so, thank you very much for this interesting talk. Thank you, Ralph, for that.